Dr. Brown, I'm curious about whether or not persons who might be suffering from depression can make an accurate self-examination or a self-diagnosis as to the presence or absence of depression.
John, let me say, first of all, what a pleasure it is to be back with you again. And as a psychologist, you know the answer to that question is yes. Interestingly, thousands and thousands of dollars or more have been spent on designing psychological tests for depression. But the most reliable, inexpensive way to find out if a person is depressed is to simply ask, are you depressed? That will be very fulfilling and rewarding for most situations. Sadly, the average depressed person is often unaware of it. And they often have to be told by someone else, a family member or a friend, that they seem to be different. So the answer to the question is yes, but a little more complicated.
What therapies have you used through the years that have been most successful in the area of treating patients with depression?
I think most people today would be expected to be treated with antidepressant medication. I believe I read that somewhere between $43 and $50 billion a year is spent each year for antidepressant medication. Some of those are very good, but like all medications, there's a risk-benefit ratio, and there are a lot of side effects that are unpleasant but can be tolerated for the severely depressed person. Medication is not indicated for the mildly or moderately depressed person. So what's left is the importance of being able to talk to someone you trust, what soldiers have come to call a qualified listener, about what they're feeling, or interestingly enough, about what they're not feeling any longer, and are overwhelmed by sadness. Interestingly, a person who is not depressed, let me back up on that, a person who is depressed and doesn't know it will often say, I have a good home, a good family, maybe a good job, but it's meaningless to me. What's wrong with me? And the answer, sadly, is very often depression. And perhaps 90% of the time, the cause of depression cannot be identified. It often is associated with a loss of some type, but most people who are depressed without an apparent reason. But it's worth the search to look for a good reason, because if you can find that reason and correct it, the depression will disappear. Now, the second kind of treatment besides medication is talking therapy. And perhaps the most widely accepted talking therapy is cognitive therapy. And this was developed by Dr. Beck at the University of Pennsylvania. And he's pointed out that depressed people have a negative interpretation of their past, a negative view of themselves as a person, and a negative view of their future. And those kinds of thoughts pervade their mind all the time. And the challenge for the therapist is to help them see the errors in their thinking. And his concept, which I think is a very sound one and one to which I ascribe, is that if you can help the person begin to think about what they're thinking about and look for the errors in their thinking, that those errors often come from deeply held beliefs that are misinformed beliefs. And the most common dysfunctional beliefs in depressed people are: 1, I am unlovable, or 2, I'm incompetent. And most of the thoughts stem from those unfortunate, deeply held beliefs, and it takes time to change those beliefs. A newer system has been developed by a colleague named Jim McCullough at the University of Richmond Medical College of Virginia, Virginia Commonwealth University actually. And he points out that depressed people are very often in the submissive, hostile domain. They're ineffective at expressing their feelings. And feelings can pervade them, but what really counts is what they do or don't do. And so he has combined cognitive therapy with behavioral therapy, and he challenges these chronically depressed people who have been depressed for 2 years or more, to begin to look at what they can do to get the desired outcomes in their life.
What do you think are some of the dangers of not treating depression?
Well, the most serious complication of untreated serious depression is suicide. And there has been an increase in suicide among soldiers in the last several years. As a matter of fact, in January of this year, 2009, more soldiers died of suicide than were killed in combat. That is an unheard of phenomenon. Now, but to be completely fair, it is still a very infrequent occurrence. So suicide for all the population in the United States is around 13 per 100,000 per year. So if you think in terms of numbers, it's a small number. When you're looking at young people, young adults who are taking their life, it's always tragic, of course. But for males, the risk of suicide increases with every year of life. And once a person makes one suicide attempt, they are then at a higher risk for trying again. So a depressed soldier who is keeping it hidden from himself and from others and is not getting treatment is at the risk of taking his life. And intervention then is very important. The Army is making a full court press program of education from the highest command down to the smallest level of function in the military, of education on what suicide prevention can be all about. One of my soldiers told me recently that these programs need to stress the importance of living and what soldiers have to live for, and not just look for the risk factors, such as substance abuse or being isolated from others, but to give soldiers more reason to want to live and to recognize them for the sacrifices they and their family make. It's a major problem. It's something that's challenging. Interestingly enough, for as long as records have been kept, suicide has been with us from the beginning of time. Even in the Bible, there are cases of well-known people who have taken their life. I'll mention this, John, and I think it's interesting that only about 12 or 13% of people who commit suicide leave a suicide note. And if we look at those suicide notes in a studious way, they will often betray the errors in thinking that's being made. So there's a lot of all or none thinking. Either I am no good and you are better off without me, or nobody ever cared for me in the first place. And it's often grammatically incorrect, inconsistent with their educational achievements. Spelling is atrocious. And it is, I think, very important evidence that the thinking has gone awry. And the challenge is to, my friends and colleagues and soldiers who are depressed, is to work on that intervention and help them remove the inaccuracies in their thinking.
And how common among soldiers is depression? What have you found through the years, and what have been your experiences in terms of the degree to which this is prevalent within the soldier population?
To be honest, we don't have any statistics on that that we can rely on, certainly. It's counterintuitive, but the number of deployments that a soldier has is indirectly related to the number of suicides. The statistics I've seen that were most current up to September of last year, 2008, showed that the suicide rate went down with each deployment. It appeared that if the soldier could make the adjustment on the first deployment, then they're less likely to try to take their life on subsequent deployments. Soldiers have a strong attachment to each other. And when they're in combat, when they're deployed, they rely heavily upon each other. That connection, that attachment is soothing and healing. And I think even for depressed people, it brings the risk down of complications. So the good question, answer, we don't know. The soldiers I see have either been sent to me by friends and family or by the post-deployment risk assessment. So a soldier is required to fill out a questionnaire, actually a computerized questionnaire, prior to deployment, and then twice upon returning. And we're finding that when a soldier first returns from combat, their answers to that post-deployment screen are not very reliable because they want to get out of there and get home for their so-called block leave. When they come back 3 months later and fill that out, then many of them will admit to being depressed and having issues related to combat, and those people then are referred to us for help. So the sample I'm seeing is biased. My guess is that suicide and depression in the military, up until now, has been no higher. As a matter of fact, it has been significantly less than the civilian aged match group. This is a fairly new phenomenon. Whether it will persist, only time will tell.
Is it possible for family members to be able to observe persons close to them and offer some kind of an identification as to whether or not the person is suffering from depression? What might family members look for when they're interacting with their loved ones?
John, that's a very good question again. Family members are the ones who suffer the most with a depressed soldier in the household. And unfortunately, this is perhaps one of the most challenging difficulties of returning from combat. Family members don't know what to ask, and soldiers are afraid and reluctant to reveal what they've gone through. And so often they hear from the family, quote, you're changed. You're not the man I married. You're not the father I had before you went to combat. And so this is a very delicate, tightrope walking situation. I would encourage families to say less and less to the soldiers when they come home about asking what went on. A very common question for children to ask is, Daddy, did you kill somebody? And why? And did these women have bombs under their dresses, and why did they do that? These why questions are very, very difficult to answer, and it's best not to raise them if you possibly can. What the wife can look for is a series of situations in which the soldier feels completely numb and is unable to express tenderness and warmth towards the wife. Many soldiers have erectile dysfunction that's related to psychological issues. And erectile dysfunction is also related to many antidepressant medications. It's very hard for a spouse who's been away for a year or 15 months to have a soldier return who has no tenderness, no ability to perform intimately, physically, and who seems to devalue the family. What can they do? They can say, honey, I want you to let me go with you to mental health to see if we can get some help for this. You are not crazy. You're not losing your mind. I think you can be helped. I know of some people who have been helped. This is what it's like, John. It's, believe me, there's suffering beyond the telling of it. And family life is very unrewarding for many soldiers coming home. They shut down emotionally before they leave to prepare themselves for the feelings that will come up while they're away. And it's hard to reopen that psychological space when they return. One of the major problems with this, and perhaps you've heard the term scanning or hypervigilance. All these people who've been in combat, every one of them, will constantly be alert for the possibility of danger around them. I thought until recently that was simply related to physical dangers. But I think it's really more personal dangers. So they're hyper-vigilant when talking to the family and talking to the spouse. I had a soldier recently who woke up in a good mood. His wife drove him to an appointment. She said something and slightly raised her voice, and he immediately went into a shutdown mode because he gave a meaning to that was not what she intended. And he didn't speak to her for two days after that. He's in therapy, she's in therapy. We were able to work through that in a married couples group, and they're both doing better on that.
Within the military, somebody who is depressed is not a person oftentimes that you can draw upon for all of the things that are associated with a mission. What kinds of things should commanders know about regarding depression and the degree to which it would affect the military's mission?
Another good question, John. Commanders need to be educated about what is known about depression and how depression will respond to treatment. So often, a depressed soldier is not going to be competent to fill the mission, except with a lot of help from his colleagues and so-called battle buddies. Battle buddies are the first ones to know when another soldier is depressed, and they need to realize they're not doing the soldier any harm if they report that to the next higher echelon for that soldier to get some help. Missions are what the Army is all about. Soldiers have to be mission ready, and frequently we're called upon as psychologists and psychiatrists to decide whether a soldier is fit for duty, and that's a very important decision. And we have our limitations. We can only say the soldier is fit at the present time insofar as we're able to tell. But a good commander will really know what the soldier is experiencing. And there's a close relationship between command and soldiers. And they can tell pretty quickly how the soldier's feeling if they take the time and give consideration and do not believe that stigma should hold the soldier back from being treated.
I'd like to bring forth the notion then of stigma and the degree to which that is difficult for anyone in the military service to kind of cope with or deal with. What would be your recommendation if someone is suffering from depression as to how to go about the process so there wouldn't be any aftermath, negative effects associated with, say, their career or their presence within the military?
John, that's a very good question about stigma. And there's a lot of misperceptions in the military as well as in the civilian sector about getting psychological help. Some people think it's a, quote, career stopper, that once you get mental health treatment, you will never be promoted. That's an absolute lie. We've had a 4-star general recently with post-traumatic stress disorder who went for psychological help, was treated successfully now, and is beginning to require people with any suspicion of mental health issues through strong encouragement to get help. Some people feel that when you're told to see a psychiatrist, it's like telling someone to go to hell. But a diplomat is someone who can tell someone to go to hell and make them look forward to the trip. And so this is an important way of using diplomacy at all levels in the military to, especially with personal testimonies, to say, I went for help and I am significantly improved. Whenever I have an opportunity to talk to groups of soldiers, I usually bring another soldier with me, sometimes a high-ranking soldier. I've had a major who has come and a lieutenant colonel who has spoken to groups saying, come aboard and get help. It's unfortunate, but through our history, we've all been afraid of going for help. And help is available. And we have some proven methods. And to be a real good soldier, you need to be checked out psychologically with your friends. And if there's any question about how stable you are, get some help. It's remarkable how changing your view of yourself can help significantly. I'll give you one case example that happened recently. And this is a kind of natural progression of depression. We had a soldier who had a very bad experience in the military in which he was in a combat zone. He was not trained to deal with human remains, but he was thrust into that position in a situation that was very dramatic. A soldier had been killed and was brought in a loving way by his colleagues. And it was very painful for everyone involved. But my patient could not get the picture out of his mind of this fallen soldier. No fallen soldier is left behind, and the highest respect is given to the fallen soldier. And what actually transpired was that he went to the memorial service, and the photograph of the soldier was on the program. He kept that program and looked at it repeatedly and could not get this soldier's face out of his mind. He came back. He would stop his car on the side of the road and cry. The fallen soldier was of a different race. His grief, unresolved and unexpressed, went into depression. The depression was untreated. He came into group therapy. He said he tried everything he knew about, but he could not get this out of his mind. And I encouraged him to not try to get it out of his mind, but to share it with us. And I went to the blackboard in the group therapy room and drew a circle around each of the characters in this unfortunate drama. And the people, the soldiers in the group pointed out different perspectives that were presumed that this soldier had not considered, like the importance of what was done at each step of the way. And the soldier had become so depressed, I put him on an antidepressant medication, and most antidepressant medications do not work for at least 3 to 6 weeks, and that's a crucial time requiring patience. And one day last week, as I left my office to go exercise at midday, this soldier drove by in a pickup truck, and he said, "I'm better, I'm better." This is the first time I've seen this soldier smile. And I think it was a combination of sharing his loss, grieving, having the complication of major depression treated, and now he is well. I think he has sustained improvement, and he's never going to forget the soldier that fell, but he will view this soldier in a very different way. The purpose of grief is to be able to remember the loss with less pain. And now he's going to have significantly less pain, and his depression is lifting.
As a last question here on the area of depression, how optimistic are you that if a person is identified early on with depression and the therapies that are available to that person, how optimistic are you that it can be treated successfully?
I am completely optimistic. I believe that depression can be treated successfully. The earlier one gets to it and treats it, the better it is. Untreated depression, as we've said, can have many complications. I'm encouraged by the good news that depression will get better even on its own. Untreated depression will tend to go away. The bad news is that it tends to come back if it's not treated properly. Even some well-treated depressions will persist in some very few cases, and those people will need special treatment, often requiring hospitalization. But overall, depression, this is important to realize, it's something that has befallen the soldier. The soldier will often say, "I am depressed," but they're not really, that's not them. Almost every other condition you say, "I have a cold, I have a broken leg, I have pneumonia, but I am depressed. That's who I am." And the physician, the commander, the battle buddy needs to drive that wedge and say, "That's not who you are. That's something that's happened to you. You're thinking like a depressed person, but that's not who you are. And we can do something to change that." If you were a paratrooper and you jumped and had a rough landing and broke your leg, you would get treatment for that fracture as soon as possible. If you've been in a situation which caused you to have a broken spirit and have become depressed, you need treatment for that broken spirit and depression, and you will get well just like the fractured leg would get well.